Morning, everyone. On the behalf of Team Dentist Channel Online, I would like to extend a very warm welcome to all of you. And I wish all the participants a very happy oral health day. It's a perfect day on Sunday to start with some good learning. And before starting with the session, I have a few housekeeping notes to make. If you have joined us from Facebook and YouTube Live, you can ask us questions by commenting, and we'll be answering them at the end of the session. If you have joined us live on Zoom, we'll be asking you questions. We'll be doing one poll session. We request you to kindly attend that. And if you have any questions during the session, you can put your questions in the question and answer box, and each and every question will be discussed and answered at the end of the session. Hello, friends. I'm Dr. Aditi Mishra, and I'll be the host for today's session on the topic The Eye See What the Mind Knows, Understanding Oral Precancerous Lesions by Dr. Vishal Punjabi. I'll be introducing him. Dr. Vishal Punjabi is BDS MDS, a consultant oral maxillofacial pathologist and practicing dental surgeon in Mumbai. He has received many awards and allocates, which includes the Pierre Fortune Academy International Senior Student Award 2014 from India. He is the recipient of Budding Dentist of the Year Highly Recommended Award 2019 and Special Jury Award Postgraduate Student of the Year Award at the alma mater MGM Dental College and Hospital, Navi Mumbai, where he completed his undergraduate and postgraduate degree as the batch topper. He is a former medical officer with the Indian Cancer Society. At present, he is faculty lecturer in the Department of Oral Pathology and Microbiology at the prestigious School of Dentistry, D.Y. Patil, deemed to be University, Navi Mumbai. He has a keen interest in early detection and prevention of oral cancer. He has extensively delivered lectures as a guest speaker on topics like cancer prevention, early diagnosis, and tobacco counseling at various online and offline platforms. He has actively participated in many international and national scientific events and won numerous accolades. He is a reviewer with reputed journals and has many scientific publications to his credit. Welcome, Dr. Punjabi.
Good morning, and thank you for that introduction. Good morning. Thank you for the introduction, Dr. Aditi.
Thank you so much, sir. Please carry forward.
All the participants, and I'll just share my screen for the presentation. Okay. Is this visible? The first slide?
Yes, sir.
Okay. So we'll begin. Before that, I would just like to mention about that when Neil Armstrong said that mystery creates wonder, and wonder is the basis of a man's desire to understand. So today, we'll be trying to understand these oral precancerous lesions because the eyes see what the mind knows. So that's the topic of discussion today. The eyes see what the mind knows. Understanding oral precancerous lesions. So before that, there's just a small exercise to get us ready for this session. So the eyes see what the mind knows. There's just a quick poll. Dr. Aditi, if you could launch that poll. Yes. So it's a request to all the participants to identify this historical landmark, one of the wonders of the world. Can you identify it? It's just a simple yes or no. We all know what it is. So can we identify it? Yes or no? Request all the participants to just.
I request all the participants, you would be seeing one poll on your screens. So kindly answer if you can identify, and you have to identify one. We have two more identifications. So you need to answer the first one. Do you identify this picture or not? I request all the participants to kindly participate in the poll and make it one interactive session. Thank you.
Yes, so do we have the poll result for this? The first one is the Taj Mahal. Yes, 100% people can identify it. That's good. So we know. So here the mind already knows what we are seeing, right? The eyes can identify this landmark, and the mind knows that yeah, this is the Taj Mahal. We move on to the next one to identify. Can we identify this second landmark? I can see there are 100% that the polling results are there. Again, this is the Eiffel Tower that we can identify because the eyes see what the mind knows. So your mind already knows that this is the Eiffel Tower in France. You can identify it. So the eyes already can see it. We move on to the next one. That is the third. So you can just quickly enter the yes or no. Do we know where this is? Can we identify this landmark? The purpose of this is just to make it more interactive. Can we identify? Everybody completed with the poll? Can make it. Yes, Dr. Aditi, I just need your help with this. Has everybody completed the poll?
Yes, I request participants to kindly give your votes on the third picture. The third picture, which you can see right now, kindly go to the poll section. You will be seeing one poll active and participate so that we can make it more interactive and you can understand better what doctor and we are trying to explain you. So we have received 80% results for yes and 20% for no for this picture.
Okay, so 80% if it's yes for the third picture, that is, this is the, okay, now I'm just seeing some new result that is 70%
Yeah.
yes. So probably there was a, like everyone voted seeing the first image itself on all the three questions. So there's no problem. I personally would have had a difficult time to understand or to locate or to identify this landmark. So this is the tallest bridge in the world, again located in France. So I feel that some like the 30% of the participants who didn't know, it's because they've never seen it. So the entire point of this small exercise was to make you understand that whatever your mind already knows is what your eyes will see. So if your mind doesn't know where this is, so your eyes won't see it. It is similar to what we'll be discussing today, that the precancerous lesions of the oral cavity, that many a times we don't know, our mind doesn't know how it looks like. So we can't see it. So we are always working around the tooth. We are always drilling, we are always filling as dental surgeons, as clinicians, as interns, as well as students. So we are always focused around the hard tissue, that is mainly the teeth. That is correct, but there is the majority of the part there is a soft tissue, so where this precancerous lesions happen. So it is not, you won't see a leukoplakia on the enamel, on the tooth surface. You will see it on the soft tissue, on the buccal mucosa, on the tongue. So it is very important to screen that area, to check that area, to examine completely, as well as when we are talking about the teeth, as well as the soft tissue. So that is what I'll be elaborating on today. So once your mind would know what to look for, your eyes will see them. Okay, so we'll move on. I'm ending the poll. Okay, we can end the poll, Dr. Aditi.
Yes, sir. Yes, sir. I've ended.
Okay, so we'll move on with the presentation. So understanding precancerous lesions of the oral cavity, today I'll be talking about the introduction, understanding the terminologies, that the precancerous, pre-malignant or potentially malignant, the etiology, recent updates, management, and what is the role of the dental clinician or the specialist, what is the role of the oral pathologist, and the case discussion that we'll have towards the end. followed by the Q&A. So I just give you an idea about the introduction. This is something like what we all, like the structure of a cell right within the nucleus, there's a DNA. So how does the precancerous process actually begin? So there is a point in that structure, right at that microscopic level, that there is a type of a mutation which occurs. So there is a genetic damage which happens at that level, and that is where we can see the changes through the process clinically. So it starts at that level. So there are 4 regulatory genes which are the main target of any precancerous process, of any cancerous process. So here we have the growth promoting proto-oncogene, the growth inhibiting, that is the suppressor genes, and the genes regulating apoptosis, that is the programmed cell death, the DNA repair genes. So these are the 4 regulatory genes that are the main target for the etiological factors like the tobacco or whatever the etiology is. So these are the target for the genetic damage which is required for a precancerous process to start. So just imagine a car. To better simplify this for everyone, so the growth promoting proto-oncogene, now every cell has a purpose, has a lifespan, every cell in our body. So basically the proto-oncogenes is like the accelerator. So when the cell is dividing, it is multiplying. So that's like the accelerator in a car. It's moving at a pace. Growth inhibiting genes are the suppressor, basically the brake and the handbrake, so which will slow down the speed. When we are moving around in the car, we are not completely accelerating all the time. We are ensuring that we are accelerating and braking as and when required. The same is with the cell. So there is a promoting proto-oncogene, that is the accelerator, and the inhibiting gene, that is the brake. So there are genes which regulate the apoptosis. So here there is something which is, and the DNA repair genes, this is like the clutch in the car. So even if you are having an automatic car, you still require it to have that transmission to understand that yes, there is a clutch which is ensuring that we are moving at the right pace. So there is something overlooking all these proto-oncogenes as well as the inhibiting genes. So here when there is a proto-oncogene, the mutation occurs at that level and then it becomes an oncogene. So the cells continuously divide. So then what we see in the oral cavity is a growth. What we see is a lesion. That is where the genetic damage occurs. So this is just to make you understand the normal cell. Here we can see, and the genetic damages as we already discussed. So those genetic damages at that level, what we see histopathologically is epithelial dysplasia, the dysplastic changes within the epithelium. What we see in case of leukoplakia, in case of oral squamous cell carcinoma. So here we can understand that dysplasia, which will be followed by hyperplasia of those cells. So when there is a proliferation of those cells, what we see is a patch in the oral cavity. We see a white patch. We'll be just, I'll elaborate more on why is it white. Why does leukoplakia? Leukoplakia literally means that it's a white patch or a white plaque, which is seen in the oral cavity. So these genetic changes, the dysplasia, atrophy, erythroplakia. So when there is atrophy of the cells which become atrophic, so there the connective tissue which is there, it is occluded, it is seen, so that gives it a red appearance, so that erythroplakia for you. So here that is where we understand that the molecular changes, like whatever these etiological factors you always see in all these messages on No Tobacco Day, on World Cancer Day, we see that tobacco is the culprit, tobacco is causing this, that, and we see certain other things like areca nut in case of oral submucous fibrosis. So the alkaloids the byproducts which it forms, how it causes oral submucous fibrosis. So that happens at a molecular level, and from molecular level it is evident histopathologically, and from that histopathologically we can see it clinically. So that's where the entire thing happens. So once we check clinically, that goes in reverse when we are seeing the patient. First we have a clinical examination, then the histopathological examination. But the process starts right at the molecular level, causing dysplasia, then hypoplasia, leukoplakia, atrophy of the cells, erythroleukoplekia, and then all the cellular changes. So here today I will be emphasizing on early detection and intervention, because if you consider the mortality rate of the patients who get diagnosed in the late stages of oral cancers, even after the surgical management, even after resection, there is a 50% mortality rate. So it is very important to diagnose it early and treat it early as soon as possible. So here we understand the terminologies of precancerous, potentially malignant, and pre-malignant. So earlier it was called as a precancerous lesion. Nowadays it's also been referred to as a pre-malignant, but these terminologies are not that accurate, because when we call something precancerous, it is like it will transform into a cancer, but that's not true in all the cases. So the accurate terminology is a potentially malignant disease or a potentially malignant disorder. So it has the potential to become malignant. That is where the treatment part comes into the picture. So today I'll be elaborating on few cases which I have managed at the early stage, at the early intervention, at the precancerous stage. So to avoid any confusion, I will be continuing with calling it oral precancerous lesion, because that is what is widely used, but it is not that accurate nor even pre-malignant. It is potentially malignant because it has the potential to transform into a malignancy, that is oral squamous cell carcinoma. So again, pre-malignant lesions and pre-malignant conditions is what we know theoretically, that there are lesions and there are conditions. So what are the lesions? Basically, the oral pre-malignant lesions, oral precancerous lesions are, as per the WHO definition in 1978, it is a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart. So here in this clinical image, you can see this is the left buccal mucosa and the lower left buccal vestibule. We can see that this is just focus on my pointer, that this is a morphologically altered tissue. So here the morphology of this tissue is altered, and here there is more likely that this will transform into a cancer. So it is more likely to occur than its apparently normal counterpart. Here we can see that this is apparently normal area, and here this is the entire lesion. It's a white lesion, it's a leukoplakic lesion with certain areas of hyperpigmentation, as we can see over here. Okay. So when we talk about oral pre-malignant conditions, basically it's a generalized state which is associated with an increased risk of cancer. So here it is a generalized state. So here the example is that of the oral submucous fibrosis that I will be discussing in the subsequent slide. So before we go on to the clinical discussion and about each of the lesions, it's very important to know, basically this session is focusing on the clinicians and the interns and the dental students as well, on how to screen the oral cavity. So why is it important? Like here, when the patient comes to us, we always have like a toothache or something. We always have patients who have, like they have a cavity or they want a root canal and all the routine work. Yes, that is always correct. That is the first step. We have to treat the chief complaint of the patient. But it's also very important, once the chief complaint is managed, you have to do a complete oral examination that includes the hard as well as the soft tissue. So you have to screen the oral cavity. It's very important to follow these steps to screen the oral cavity. So just to see here in the schematic, how we have to retract, how we have to palpate, and how we have to visually examine under the amber light or even the white light source. You can see all these parts are something that we miss out on. We just focus on the tooth and we are like, okay, what if the patient had a tobacco history? What if there was a early, like an initial pre-leukoplakic lesion? So that could help save a life. Ultimately, that no one can predict that this kind of a lesion will suddenly become like a oral squamous cell carcinoma, or it will progress at what stage, or it will metastasize. So that is very important to understand. That is why the soft tissue examination, that is the screening of the oral cavity, is very important. So here, that is the retraction for the gingiva. We check all the soft tissue around the tooth. This is the upper lip. Here we can see that the hard palate examination, and not only restricting it to the oral precancers, but even certain salivary gland tumors, malignancies are seen very commonly in the minor salivary glands in the hard palate. So it is very important to examine tonsillar area, that is the posterior part of the palate, the soft palate area as well. Oral submucous fibrosis, blanching, generalized, very many changes are seen in that area. And here in the buccal mucosa, the tongue, it's very important to use a sterile gauze piece to ensure that the ventrolateral surfaces are examined. The cancers or the precancers in the floor of the mouth are having a very poor prognosis. So it's very important to examine these areas. Okay, so this is how we do the cleaning of the oral cavity. So here we begin with the lesion, that is Leukoplakia, a precancerous lesion. So basically it is a white lesion. It is also like a white patch. Leuko means white and plakia means a patch or a plaque. So it's a white plaque. Other terminologies, I say like a leukokeratosis. It is potentially malignant. It is precancerous or pre-malignant. So potentially malignant, based on the definition of a leukoplakia, it is a predominantly white patch occurring on the surface of the mucosa, which cannot be scraped or rubbed off and which cannot be attributed to any other clinical or histological disease. So there is a modification to that definition. Basically, it's a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. So some oral leukoplakias will transform into cancer. So the definition, which is the latest, is basically it's a white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. Now, most commonly we encounter other white lesions like candidiasis, oral candidiasis. So there it is not a leukoplakia, it is misdiagnosed many a time. Everything white is not leukoplakia. So here the white plaque which is seen in case of a leukoplakia, it will be non-scrapable. It has a questionable risk, so you have to exclude. So based on exclusion, the clinical diagnosis, a provisional diagnosis is made. That is that it is excluding the other known diseases or disorders that carry no increased risk for cancer. Now, oral candidiasis per se has no increased risk for cancer, just as an example. So that is why it is very important to exclude other lesions to have a provisional diagnosis of leukoplakia. And it's very important to know that leukoplakia is only a clinical diagnosis. On histopathology, we never mention it as a leukoplakia. We always mention the amount of keratosis, whether it is hyperkeratosis, and also the dysplasia which is seen. That is the genetic and the histological mention that I made the mention earlier related to the genetic damage as well as the histological changes we see. That is the dysplastic changes we encounter in the epithelium. So these lesions were once upon a time called as red and white lesions. So red and white was it related to the tobacco product which was of the same name, that is a red and white lesion? Why are these lesions white? Like why is leukoplakia white? Here we can see that leukoplakia is amount of hyperparakeratosis or hyperorthokeratosis that we see histopathologically. But here the entire thing is that the keratin which is produced is abnormal. So that keratin will imbibe water and it will appear more white. That's why it is appearing white. And here in this particular case, there are certain areas of hyperpigmentation also which is seen. Here we can see like it's a milky white lesion. So that is why these white lesions are white. So as we already know, the etiological factors, tobacco, gutka, pan masala, all these products, cigarette smoking, bidi smoking, all these are the tobacco products which are the etiological factors for precancerous lesions. Alcohol, now alcohol has a synergistic effect with the tobacco. Now it's very common that some of the people out there who are smokers or who use tobacco products also are heavy drinkers. So both of these things have a synergistic effect. Basically the alcohol, it actually dries up the mucosa, wherein the harmful effect of these tobacco products is even more because they are in contact with the mucosa right at that level. Apart from that, we've always known about this is just like a revision of the etiological factors. Basically, the sharp tooth or anything like a molar, which is broken cusp, broken tooth here, which is going to cause irritation, which is a chronic irritation to the surrounding mucosa, especially the tongue, because that's going to move around. That can ulcerate the tongue. So it's very important to get the etiological factors treated. Apart from the other etiological factors are basically oral candidiasis. In certain areas, the oral candidiasis, the candida infection which happens, which is a super infection on these lesions, basically that can also give rise to dysplastic changes. That some amount of recent research has mentioned that because there's some nitrosamines which the candidal hyphae secretes around there and causes the genetic damage. Apart from that, dietary factors are there, that the amount of vitamins that the daily requirement is, the daily nutrition is not adequate. That can also be the etiological factor. What are the clinical features of a leukoplakia, that is a precancerous lesion? So here we can see that this is on the left buccal mucosa and the lower left buccal vestibule. You can see that it is a well demarcated lesion, well demarcated. Compare it to the surrounding mucosa. You can see, if focus on my pointer here, that this is the area which is seems to be like a normal counterpart, and here is where the lesion begins. You can see it is a morphologically altered tissue, a white lesion. It is extensive. These are the clinical features. So apart from that, clinically you can just classify a leukoplakia into homogeneous and a non-homogeneous leukoplakia. Speckled leukoplakia, that is the non-homogeneous. So there will be certain areas where there will be some erythematous changes. Now, apart from that, leukoplakia has many variants. So what are these variants of leukoplakia? So here, just to simplify it, there is something known as a pre-leukoplakia, which is not that well defined, but however, it will not be that white as well, but it will be a pre-leukoplakic patch. How we clinical picture, that it was a very evident kind of a homogeneous leukoplakia. Apart from that, there is a non-homogeneous, as I mentioned, that we will be seeing in one of the case discussions. There will be an ulcerated nodular, a verrucous leukoplakia, a proliferative verrucous leukoplakia, which is of major concern, and the erythroleukoplakia. So PVL, that is the proliferative verrucous leukoplakia. So here there are multifocal areas are involved, and it has a high recurrence rate and a very high rate of malignant transformation, almost 60 to 100% of malignant transformation. So it has a high recurrence rate as well. So it's very important. It's a rare form of leukoplakia. It was first reported by Hansen in 1985, and it is a more aggressive biologic behavior which is compared to the homogeneous or the non-homogeneous leukoplakia. Very important to know how to diagnose this clinically is that there are multifocal areas which are involved. So here we have a image of the multifocal areas. We can see it is not just restricting to one side or one area or one site in the oral cavity. When we saw the previous clinical picture, it was on the left buccal mucosa. Here we can see it is like spreading. It is almost spreading type of a leukoplakia. So this is a proliferative verrucous leukoplakia. Very important to know, the reason being that it has a high recurrence rate of 87 to 100% and a high malignant transformation 60 to 100%. So what are the histopathological features? Now we discussed the clinical features of leukoplakia. We understood that okay, that area is where the morphologically altered tissue is. So why is it appearing white? Again, as I mentioned, there is because the amount of hyperkeratinization, that is the hyperorthokeratosis in this case histopathologically here, just see on my pointer here, and the parakeratosis and acanthosis, basically the spinous cell layer increases. So here we can see that there is hyperparakeratosis. So this is the abnormal keratin which is formed, and then that imbibes water. So there are certain areas in the oral cavity where there is, it's a non-keratinized epithelium, but in case of leukoplakia, it forms abnormal keratin, and that causes that water to get imbibed, and that causes the appearance of a white lesion. That's why it's called leukoplakia clinically. So histopathologically, we have the dysplastic changes that I mentioned, which were followed by, before that there's a genetic damage. So what is the epithelial dysplasia, the features of epithelial dysplasia? So there is cellular atypia, there is pleomorphism, there is variation in the size and shape of these cells. Here you can see in this particular image of a leukoplakic lesion. This is the histopathology. Basically, after the biopsy, that is where this comes into the microscope and we can observe these changes. Hypochromatic nuclei. Here we can see hypochromatic nuclei, hypochromasia. There is a altered nuclear to cytoplasmic ratio. There are mitotic figures which are more abundant. Here we can observe some mitotic figures over here. So these are the few epithelial dysplastic changes which we encounter in case of leukoplakia. Loss of cell polarity as well. So moving on to the treatment. So it is very important to eliminate the etiological factor, or if there are certain etiological factors which are not removed, like for example, we treated the leukoplakia, we got a biopsy, we came to know it is mild, there is mild dysplasia in that, and we never like got the etiological factors, the habit of tobacco, so like cigarette smoking, etc. We didn't get that eliminated. So again, that there is a chance of recurrence or maybe even a malignant transformation. So it's very important to eliminate the etiological factors, whether it was tobacco, whether it was alcohol consumption, or whether it was even a sharp tooth. Conservative therapy is with the help of pharmacology, basically the drugs which are given, that is topical application or whether it is a systemic administration. Surgical approach is you just basically have a wide excision, as I'll be discussing in the case discussion part towards the end. That's the surgical approach, the management of the leukoplakic lesion. So tobacco, alcohol, cigarettes, and remove the chronic irritant, that is the elimination of the etiology. Conservative therapy consists of topical and systemic, as I mentioned. So topically you can give vitamins, basically antifungal as well, because there are chances of a super infection of oral candida albicans. Basically, candida albicans is one of the most opportunistic infection in the oral cavity. So whenever it finds an opportunity to multiply and spread and infect, so it does that. So antifungals are given, topical antifungal, like a candid mouth pain. Vitamins like a retinoid gel or a vitamin A topically can be applied. If there is a symptom, you can also give topical, like a local anesthetic for the topical application. Apart from that, again, multivitamins are given systemically. If needed, then antifungals can also be given systemically. And antioxidants which are there, the beta carotene, lycopene, which are the SM fibro, which is commonly given. So systemically, beta carotene, lycopene can be given. This is the conservative therapy. And the surgical approach being that of a conventional surgery with like a wide excision with the scalpel. A cryosurgery, electrosurgery, lasers, ablation, all these treatment options are available for the surgical management of leukoplakia. So after that, once we discuss leukoplakia, the other common thing nowadays which we are encountering as a pre-cancerous lesion is basically termed as lichen planus. This is oral lichen planus. Lichen planus is basically an immunologically mediated chronic mucocutaneous disorder. It affects the oral and the genital mucous membrane, the skin, nails, and the scalp. So lichen planus commonly affects the oral mucosa, which is termed as oral lichen planus. Sorry. So the prevalence of oral lichen planus worldwide is 2.2%, and in India it is slightly higher, it is 2.6%. So why is it called lichen planus? In case of leukoplakia, we know now why it is called leukoplakia. Leukoplakia, leukos means white, and plakia means like a plaque or a patch, so a white patch. So lichen planus is basically derived from the Greek word lichen, which means a tree moss, and Latin word planus, which means plaque. So I'll be training the mind right now to see that, so the eyes can know that, okay, this is the lesion, this is the difference between a leukoplakia and a lichen planus. What are the clinical features of oral lichen planus? So the age of occurrence is slightly higher, above 40 years of age. There is a female predilection. The male to female ratio is 1 to 1.4. That is basically a slight female predilection. Again, the etiological factors, as when we discussed, there is more related to stress and anxiety. That is the oral lichen planus. The common site are the buccal mucosa. More like the most common is the buccal mucosa, followed by the tongue, lips, gingiva, and the floor of the mouth and palate. So the World Health Organization has given certain criteria to diagnose oral lichen planus. Basically, the clinical criteria is there as well as the histopathological criteria. So when we see the clinical criteria, they have mentioned that based on the modified WHO criteria, there is a bilateral or more or less symmetric lesion. So there has to be bilateral symmetric lesions in this case. It's like a raised gray-white line, like a reticular pattern, which is the lace-like network of slight loops. This is what we'll see clinically, and I will be just elaborating more on that as we discuss the cases. Histopathologically, there is well-defined band-like zone of cellular infiltration, which is mainly seen next to the epithelium, the extra-epithelial. So there is liquefactive degeneration in the basal cell layer. There is absence of epithelial dysplasia. So here it's very important to know that in case of leukoplakia, we do see epithelial dysplasia, but here there is absence of epithelial dysplasia. Here clinically, when we can see these gray-white lesions, so there is like once you have seen such a case. Now this case was referred to me by a colleague of mine. So here we can see that the patient had complained clinically of a burning sensation. There was no history of tobacco. Everything will be negative. But is it leukoplakia? Is it so white or is it so like a resembling leukoplakia? It didn't seem like. So here there are gray-white lesion which we see on the left buccal mucosa as well as on the right buccal mucosa. So again, based on the WHO criteria, it was bilaterally present and it was almost symmetric. So that is where clinically we got an idea that yeah, this can be oral lichen planus. Already the biopsy in this case was done, but then it was repeated and we checked histopathologically. That earlier diagnosis was of a leukoplakia, but in this case we came to know that histopathologically also the findings are consistent with in case of the modified WHO criteria that it's the oral lichen planus. So here we can see that the epithelium, juxtaepithelial to that, there is a chronic inflammatory cell infiltration, as you can see here, slightly enlarged view on the lower right. You can see that this is a stratified squamous epithelium, and there is band of chronic inflammatory cells. Certain areas on the higher power did show that there is a liquefactive degeneration layer. So this case was then managed conservatively. In the first week, this was the lesion. I'll be elaborating on what treatment modality was opted for. So here, in the first visit, as you can see, the lesion in the 1 week follow-up, that is after 1 week, we could see that it is almost regressing. And in the second week of follow-up, we saw that the lesion was completely, like 90% of it was gone, but the symptoms had subsided just right after 1 week of the initial treatment. So when we talk about the management of oral lichen planus, there is a pharmacological, non-pharmacological, and natural. So natural are some Ayurvedic treatment modalities which can be used in certain cases. So here pharmacologically, when we see again antifungals, because oral candida is basically the most opportunistic infection, so antifungals can be used. Topical steroids, corticosteroids like Kinacort, etc. can be used. Here, immunosuppressant, tacrolimus. So in this particular case, we managed it with topical immunomodulatory therapy. That is the tacrolimus. That is the immunosuppressant. Because it's like an autoimmune disease. So it is the cells are actually attacking the cells of the body. So there we had to use the topical immunomodulatory therapy with tacrolimus. So then that was the line of treatment we opted for. Apart from that, apart from the pharmacological management, there is a non-pharmacological, that is with the photodynamic therapy, photochemotherapy, low-level laser therapy, which can be used in case of oral lichen planus. Natural, we know that aloe vera, curcumin, that is, and the lycopene, again the antioxidants, green tea extracts can be used in case of the management of oral lichen planus. Now, once we are done with oral lichen planus, I would like to talk about oral submucous fibrosis. Again, this is what we commonly see as one of the oral precancerous lesions, very common in our part of the world, because oral submucous fibrosis basically is a chronic progressive scarring disease that predominantly affects people of the Southeast Asian origin. So there is a compelling evidence to implicate the habitual chewing of areca nut, basically the supari, what we call in Hindi, that is the areca nut. So areca nut is basically the etiology, main etiological factor, areca nut chewing. So they add this in pan, they add this in even gutta, pan masala. So here chunks of areca nut are chopped into fine bits and they are added, or they are even ground and they've added into these products. So that is basically the etiological factor. The alkaloid areca nut, basically it forms the arecolin. The onset is insidious and over a 2 to 5 years. Like it is basically a chronic disease. It's a chronic insidious disease. So the onset is chronic, at least 2 to 5 years. That is the type of history patients would give, that I did feel that something there was becoming a little firm in the cheek, or I could feel that there was an ulcer initially. I could feel that yeah, my cheeks are getting harder on both sides from the inside. I can't open my mouth. So these are the symptoms that the patient gives. Initially, the patient include the symptoms include that burning sensation in the mouth when consuming spicy food. So that is one of the common symptoms which we encounter, that there is a burning sensation in the mouth when they have spicy food. Oral submucous fibrosis has a malignant transformation rate of 7 to up to 30% based on the literature. So it is very important to diagnose it early and intervene at the right stage before it transforms into a malignancy like oral squamous cell carcinoma. So that is where we have to ensure that we do a complete screening. As I am re-emphasizing again, so oral submucous fibrosis, we see in this particular case that we had managed. Now the management of this case was very interesting. I'll get to that. But before that, we'll just see the before pictures, that is basically on the first visit. So here the patient had a decreased mouth opening, approximately inter-incisal distance was around 25 millimeters. Intraorally, we could see that on the right and left buccal mucosa, there are areas like it's a generalized blanching, which you can appreciate here with certain areas of erythema. The patient had difficulty in mouth opening. The patient had a complaint of burning sensation in the oral cavity. This was on the first visit. You can see here, there are some areas of erythema and some areas where there was like some minor ulceration. Yes, you can appreciate it here on the left buccal mucosa. So this was the management of this particular case with a follow-up. So after every 2 weeks, the patient was advised to complete the follow-up. The sixth visit is basically after almost 2 months that we saw the patient. We can see here that the erythema which was seen on the first visit had reduced. You can see here that the erythema as well as the blanching, some amount of blanching, not completely gone away, but the patient had the symptom of burning sensation which had reduced drastically. Similarly, the inter-incisal distance had increased by 10 millimeters. So that was a very good response we got in this particular case. So histopathologically, I'll be elaborating more on the treatment modality. That was just to show you the features as well as the management of that particular case conservatively. So histopathologically, just to give you a brief idea, there is atrophy of the epithelium here, atrophy of the epithelium, and there is a lot of these fibrosis, which what we see, oral submucous fibrosis. So here we can see in the connective tissue, there is some amount of perivascular puffing as well, what we see, some amount of inflammatory cells here and there, but the epithelium becomes atrophic, and the dysplastic changes may also be seen in case of the epithelium in case of oral submucous fibrosis. So as I mentioned, I'll be talking about the treatment. So here again, the elimination of the etiological factors is one of the main things. So in our case, that patient had already left his habit of chewing the supari and the pan masala gutka, what he used to have. So that was already eliminated. And after that, because there was persistent burning sensation, the patient had approach here, that there is still burning sensation and decreased mouth opening. So the other line of treatment is the conservative therapy, is what we opted for in that particular case. Here, the treatment with related to oral physiotherapy is something that we need to consider. Oral mouth opening exercises, basically. So mouth opening exercises, how to go about it, which one to advise in what particular case. And the last is a surgical approach, that is in case of a stage 4, like a advanced case of oral submucous fibrosis, where the mouth opening is very, very less, around 10 millimeter, even lesser, that in case of a surgical approach can be taken as a treatment modality. Now, the management of OSMF, here we see there are treatments when based on this particular article, the treatment of oral submucous, the controlled trials which are there, the cessation of the betel quid, that is the pan, because again in the pan chewing habit they have the supari which they use, pan masala and gutka supari, etc. So the areca nut, that is the supari, is what is the present in one of the components in the betel quid. So that is the where you have to stop that habit. Aloe vera is like some of these treatment modalities are there where Ayurvedic treatment has been offered. So in that particular case, we had used basically curcumin. So in our case, we did go for a Ayurvedic treatment modality. So that is just to based on the literature, and because it was an Ayurvedic treatment modality, so the curcumin, that is the powder for that, was used. Basically the haldi, what we call, and we advise the patient to mix it with glycerin and apply it thrice daily for at least 10 days, and after that we kept a follow-up, and we kept a strict follow-up. So strict follow-up is also part of the treatment. So here, when we discuss the other treatment modalities, there are hydrocortisone, that is there are various corticosteroids and the steroids which are used. Then here we see one of the treatments which are physiotherapy that we mentioned 5 times a week. So that is, in this particular case, the outcome was that there is a better than no treatment or local injections with hyaluronidase and the steroids. So that is basically there is a better outcome which was seen when the oral physiotherapy is advised in case of oral submucous fibrosis. So lycopene, here we can see 16 mg per day is being given. That was better than the placebo in this particular case. So the references are mentioned here. The main references from this particular article on the treatment modality for oral submucous fibrosis. So we can understand that the management is for the conservative way. So to elaborate more on the oral physiotherapy, I would like to say that the mouth opening exercises are something like a jaw stretching exercises. We advise the patient to stretch their jaw within limits, not excessively, and very gradually applying pressure with their own index finger to stretch and open the upper and lower jaw to separate the jaw. Or apart from that, there is an ice cream stick exercise wherein we advise the patient to stack up ice cream sticks and hold it in between the incisors, or add more number of ice cream sticks gradually. Initially, if they can hold at least 15 ice cream sticks, they can add 2 more, 5 more, gradually increase it to that level. So normally the inter-incisal distance is somewhere around 30 to 40 millimeters, depending, 35 to 45 millimeters in some cases. So that is where these oral physiotherapy exercises are very helpful. Apart from that, there is a exercise where you can ask the patient to use a balloon to blow air. Basically, they can just blow in that air on in the balloon, and it will help with the cheeks. They will have a pressure which will be building up inside, so that will help with the mouth opening as well. The fibers will basically, the fibrosis which happens in case of OSMF will reduce gradually. It is not going to have an immediate effect because it is a chronic disease. So the treatment will also be the management part is a long process as well. Apart from that, in case of advanced cases and severe cases of OSMF, the surgical approach is there where the fibers are cut off, or whatever is that the lasers are used nowadays in case of or superficially that tissue which is there, the fibrosis which has happened, the laser can be used to ablate that tissue out in that case of advanced oral submucous fibrosis. So just to elaborate here, when I'll be just moving to the case discussion, what is the role of the dentist or the specialist? Now, every dental practitioner out there, every intern out there, who or even the dental students, they are seeing all the patients. They are seeing patients. Like most of them are complaining of a toothache. Most of them are complaining of a bad breath. But that's not a hard and fast rule that they are not consuming tobacco or they are not keeping pan masala or gutta packets along with them. So they are having these betel quid, these habits as well. So you have to ensure to perform a complete oral examination. So the role of the dentist is to basically take a thorough history, always ask for a tobacco related history. And when we talk about the complete oral examination, again, that is the hard as well as the soft tissue. Always, yes, you always have to go ahead with the chief complaint of the patient. Now, if a patient is coming to me with a complaint of a toothache, I will not say no. First, I have to check the entire soft tissue, and if there is a lesion, only then we'll do the no. The chief complaint has to be managed first, but the patient has to be educated that if you are having a tobacco history or if you are even smoking casually, we need to go for a screening process. So, and also we have to always ask for a diet related history. What kind of food is the patient? Are they having a nutritional diet? Are they ensuring that the daily recommended allowances of the vitamins and minerals are there? Because certain cases where there is a deficiency can also be like a added factor that when we are encountering such like these precancerous lesions, it is very important to make the patient understand that why are we checking, what are we checking, and what will be the outcome of that. Is it normal, or will we require a consultation with a specialist? Is there anything suspicious about it? Like some of the cases that I encounter, patients are not even aware that there is a lesion because the leukoplakia is not going to cause any pain initially. That burning sensation that comes eventually. We don't want it to be too late. So every 6 months when the patient comes for a cleanup or every 6 months when there is a follow-up, it's very important to also do a soft tissue examination thoroughly. So this is again to just like a recap of that, how do we do the screening. So that is the role of the dentist, like a general practitioner or even the specialist from other various specialties in dentistry. That whenever we encounter, we are treating the patient as a whole. We are not just treating one root canal or one implant. We have to always screen all the areas because most of the people out there are having stress anxiety, which is the etiological factor for oral lichen planus, which again has a malignant potential. So similarly, some of them are having tobacco products, some of them are having alcohol history. So that is very important to know and to screen. So that is the role of the dentist or the various other dental specialists. What is the role of the oral pathologist in this case? So a clinical examination or screening of the oral cavity, if you are not confident or if you would not know much about it. So this is where you can know how to clinically examine, or you can consult with the oral and maxillofacial pathologist, where apart from that, they can also have a role in the patient education and motivation. So once we educate the patient that, okay, this can be there, because they are aware that, okay, the cigarette packet which they buy, there is an image of oral cancer on that. But they're like, okay, that's not a big deal. जब भी होगा तभी देखेंगे. Like that is the thing what the patients say. But you have to educate and motivate them because when they're coming to you. Tobacco counseling is one of the roles of the oral pathologist. How to stop their tobacco habit, how to counsel the patient for tobacco habit. That is one thing that many of the patients say that they have a difficulty, especially in the morning when they wake up, that they want their tobacco, like they want their cigarette or their bidi, so that they can get on with their day, or they want to place that tobacco, betel quid or whatever that they use, the flake lime as well as the tobacco that they make, and they place it in their cheek. Basically, that counseling that is very important because in the morning the nicotine hunger is there in the body. There are various substitutes available. There are the Nicorette, like these nicotine chewing gums, etc. are available. Patches are available. So tobacco counseling is something which is very important because they are not particularly addicted to tobacco. They are addicted to the nicotine which is present in the cigarettes and in the tobacco products. Then apart from that, the role of the oral pathologist is related to the biopsy, the histopathological examination, the punch or the incisional biopsy. Excisional, again, a wide excision. Definitely, we have a team wherein the oral surgeon plays a major role in that. And that's when the cases need to be consulted with the expert. And then the overall follow-up of the patient is very important because follow-up is also a part of the treatment. Every 6 months, every 3 months, or every month, it depends on the severity of the cases. So here we can just conclude with the clinical case discussion. There are somewhere around 8 cases where all the participants can again vote. I'll just require Dr. Aditi your help. So this will go case by case.
Yes, I've launched the poll again, and I request all the participants to kindly participate in the polling one by one. Okay, so a moment you'll see case one, you need to answer on case one, and likewise till the last case.
Yeah. So this will be the first case. I'll just share the cases. I'll just hold. So the first case, you can see the options. So just select the options for the first case. There are 8 cases, so they are all numbered, and the coincidental number will be on your screen. So this is the first case. So what can this lesion be? Because we've discussed all this, so I want to train your mind to see. So that is the whole purpose of this session. So what can this lesion be? Can you identify this lesion, whether it's a candidiasis, whether it's a candidal infection? This is on the right buccal mucosa. This is on the right buccal mucosa of the patient. Is it a leukoplakia? Is it a pre-leukoplakia, or is it none of the above? You can all select the answer which you feel is correct. Hope everyone is awake.
I request all the participants to kindly answer what do you feel, which lesion is this. So we'll see that this is, we are not examining anyone. You can be open. What do you feel?
You can be wrong. There's no problem. I'll be elaborating more on all these cases. It's basically to make you aware or make you understand that this is how the lesion would look like. So there is no, I won't be calling out anyone's name. I don't even know who's voting for which lesion. So please participate. There's no hard and fast rule.
Polling is anonymously done, so no need to be worried about that. So you can answer what do you feel, is this candidiasis, leukoplakia, pre-leukoplakia, or none of the above? I hope participants can see the polling on their screens right now. I request the participant, if you can see the polling on your screen, just can you just confirm in the chat box that you're able to see the polling section? Okay, so now I request that you kindly participate in the polling so that we can move forward. Okay, we have received answer leukoplakia.
Okay, so everyone is thinking it's leukoplakia. Okay, so I'll just discuss on this case as we finish with the poll. So everyone, 100% results are for leukoplakia. So just to mention that this is not a leukoplakia. Again, here it's a pre-leukoplakia. It is a very small lesion. As you can see, it is well demarcated, but somewhere it is even just blending with the normal mucosa. It is not that well demarcated, and plus the size of this lesion is comparatively very small. Here we can see that it is hardly like it's just around less than 1 centimeter. In some areas it is well demarcated, but is more of a pre-leukoplakia than a leukoplakia. The first one was a little tricky one. We'll move on to the next. Now you know the difference between what is a pre-leukoplakia and a leukoplakia. Okay. So this is the second case. Request everyone to vote. Can everyone see this case? This is case number 2. Not in the chat box. I think everyone's responding in the chat box. Can everyone see the poll? You can unmute and interact. This is the interactive part of the session. We are almost concluding after this case, after these cases.
Option for this case is leukoplakia, OSMF, tobacco pouch keratosis, or none of the above. You can see one lesion on the labial mucosa. So you have your options. You have the polling. Kindly participate in that so that we can move forward. Okay, so answer is tobacco pouch keratosis, what we have received right now.
Okay, for the second case, we have received tobacco pouch keratosis. So that is again in this area, it is not completely true. I have a case of a tobacco pouch keratosis in the work. So that way, here this is actually a leukoplakia because this is extensive lesion. It is non-scrapable, and tobacco pouch keratosis, and when we compare it with the leukoplakia, tobacco pouch keratosis is going to be a scrapable lesion, as we'll be discussing in one of the next cases. So here, when we have, this is a leukoplakia, which is a white patch, which you see. Here, some amount of tobacco stains are there. That is particularly because even they are present on the teeth here, because it's a chronic tobacco chewer patient in this particular case. So this is a leukoplakia, not a tobacco pouch keratosis. Move on to the next case. That is the third case. Here, I think the polling results are already in, and I can see that in the third case, it is mentioned as a OSMF 100% vote, what we have received in case of the OSMF. So this is again not a OSMF. Here we can see that this is a well demarcated lesion. Here we can see that this is a white plaque. So leukoplakia has many variants. Some of them are homogeneous, some of them are non-homogeneous. And leukoplakia is one of the most common oral precancerous lesions. So keeping that in mind, again, this is leukoplakia. I'll move on to the next where we can also see particularly this is I think the poll results are already in. This is the fourth case. They've mentioned that the options were leukoplakia, tobacco pouch keratosis, or both of the above, or none of the above. So many participants have mentioned that both of the above. But here, this is the case of tobacco pouch keratosis, where we can see that in this area, you can see that the superficial, that keratin which is there is scrapable. This is scraped out. So even when you palpate and we check these lesions, or we can use a sterile wooden stick or a sterile gauze, we can see that that area will get scraped off. So that is the feature of a tobacco pouch keratosis. That's how we differentiate between tobacco pouch keratosis and the leukoplakia. This is a tobacco pouch keratosis. Moving on to the next case, here we have the lesion on the right ventrolateral surface of the tongue. Hopefully everyone can see the polling, like they have the options on their screen that we have received in case of the fifth case is lichen planus. Okay, so this is mentioned as lichen planus by all the participants. This is actually a case of leukoplakia again. You can see that it's a well demarcated lesion present on the right ventrolateral surface of the tongue. Lichen planus was we've seen earlier in the case in the clinical features that it is a gray white lesion. It is not a patch. It is not a plaque. It is not raised. We can see that that's the difference in case of leukoplakia. Here we can see that it is present on the right ventrolateral surface. This particular patient had a history of supari chewing as well as tobacco chewing. So that is the particular lesion of a leukoplakia present on the right ventrolateral surface of the tongue. Move on to the next, that is the sixth case. And this is a very simple one. Again, it's a leukoplakia, similar size, but the only thing is that the size. So this was the difference between the size. In the earlier case, we saw that it is such an extensive lesion, and here it is just an initial lesion. So early detection and intervention at the right moment can save a life. Again, that was the case of leukoplakia. Now this is something interesting. This is a case where it's present on the right buccal mucosa. we can see, identify the lesion. So here it is, I guess, mentioned as I'll just check the polling results. It is erythroplakia, and that is correct because it is present right on the right buccal mucosa here, and we can see that certain areas have a white lesion, a white patch, and that is interspersed with the erythematous area, that is the erythro part. This is the erythro part and the leukoplakic part. So it's erythroleukoplekia, right, extending right up to the posterior part of the buccal mucosa here. Okay, so here this is correct. Everyone has got this one correct. This is erythroleukoplakia. Okay, we move on to the last case. This is case number 8. Here we have, this is in the posterior part of the palate. Here we can see that's in the tonsillar area as well. We can see some amount of, that's a white lesion over there. The polling results are there of lichen planus. Or we can see, okay, no, there's a 50-50 polling OSMF and lichen planus. 50% participants feel it is lichen planus, 50% feel it is OSMF. So here I would like to just mention that this is very close, like 50-50. Now it is changing to 67 for lichen planus in favor of lichen planus and 33% for OSMF. So here what we can see is not lichen planus. This is oral submucous fibrosis where we see generalized blanching in the posterior most part of the palate. That is one of the first signs. Here we can see that the uvula is atrophic. The uvula is atrophic. That is also a feature that we see in case of oral submucous fibrosis. Oral lichen planus is basically going to have a reticular or like a net-like pattern, and this is not one of the most common sites for oral lichen planus. That's again when we exclude, and this is a common site for oral submucous fibrosis where we can see that this area has started with the fibrosis. It is becoming white. As we can see, it is blending with the normal mucosa. It is blending with the normal mucosa. If this area particularly, for example, would have been raised or would have had a well demarcation, it could have been a leukoplakia. Here we can see it is blending. It is blending with the normal mucosa. I think these cases are basically, I had kept these cases to train your mind to understand what to look for. That yeah, we can see in this, but I'm just ending the poll right now. This was the last particular case. So here we can see in this, I'll just give an example in this case. We can see that this patient in the last year molar has an old silver filling. Here he has a little decay in the molars. So these things can be done. Your patient might complain that yeah, I want to get the silver filling changed. I want to get this decayed tooth filled. So apart from that, it is our duty to just also examine the surrounding soft tissue, because we might be treating this tooth particularly in the lower molar. But in the other areas, we might see that there is blanching. We might see that, okay, so this could be an initial sign. So this patient can be made aware. He can be educated that because you were having that tobacco habit, that this particular change is seen. So this is the line of treatment. We can go for conservative therapy. We can go for surgical management. But he is at least made aware, and that will help even when he will stop the particular tobacco or the pan supari habit that are deteriorating the oral mucosa, and in the future that can prevent a transformation, a malignant transformation, and it can potentially save a life. So potential malignant disorders, that's why we need to check or screen for them as early as possible and intervene at the right stage. So with that, I would just move on at the take-home message for everyone to perform a complete oral examination. That is the hard as well as the soft tissue. Consult or refer to a specialist if you suspect a lesion. It is always better to refer the patient or to consult with a specialist. Biopsy or the histopathology which is done is the gold standard to know the amount of dysplasia. That's the gold standard to diagnosis. That is the biopsy, whether it's an incisional, whether it's a punch biopsy, or whether it's an excisional biopsy. Always consult with the oral pathologist. Early diagnosis and intervention can prevent malignant transformation and potentially save a life. So be a part of the global movement against tobacco and prevention of oral cancer. With that, I would just extend that if there's any question and answer, or if there's anything, you can contact me. You can ask me right now as well. There's no problem. We are almost finished up. And a big thank you to Dr. Aditi and Dentist Channel Online. It So for all the support which was needed today. So thank you for providing this platform to talk about the oral precancerous lesions.
Thank you so much, Dr. Vishal, for giving us so much of knowledge. And I'm sure that all the doubts and all the dicey things that we had during, diagnosing the lesions, it has been cleared. So before I request all the participants, if you have any doubts, you can put your questions in the question and answer box. And meanwhile, you put your questions, I'll be introducing everyone to our channel, Dentist Channel Online. I request all the participants to kindly drop their questions in the question and answer box. So we are Dentist Channel Online with the motto Healthy Smiles, Wealthy Lives, and we have come up with a brand new website www.dentistchannel.online. We are on Facebook, Twitter, Instagram, LinkedIn, YouTube, WhatsApp, and Telegram. And we are proud to announce that we are the first digital dental media marketing company which is catering to academic, professional, and commercial needs of dental students, practitioners, organizations, businesses, and dental industry leaders. We offer several services and a variety of platforms under one roof. So these are the services that we provide to the professionals, students, to the organization, businesses, and people. And if you subscribe to our Prime membership, you can avail a lot of benefits. Like you have attended today's webinar and you will be receiving e-certificate, which will be containing one FDA Germany CE point, and it is only and only for the Prime members. The annual Prime membership will cost you just for 799 rupees. And if you're using my promo code, which is ADT100, you can avail a discount as well. So I request you to join our Prime membership today itself. And do not forget to use my promo code ADT100. To follow up with our upcoming events, I request participants to kindly save this number and send your name as a text message on this number so that you're added to our broadcast list and you will be updated regarding each and every upcoming events that we have. Our sponsor, Novamind GmbH, they have the innovative dental and healthcare solutions to ensure our success. They have generic implants and prosthetic solutions. If you have missed out our live session, you can go back and revise. If you have missed out some point, you can revise the points on Facebook and YouTube. We will be finding our recorded sessions there with the handle Dentist Channel Online. So let's move on to the question and answer session. Okay, so first is I'll be taking from Dr. Bhavesh. He's saying that it was a great session, sir. He doesn't have a question, but he would like to know how to tell patient if he or she is having precancerous lesion because they get panic when they hear cancer.
Yeah. That is a very commonly thing all of us we encounter as a dental professional, because the patients are not coming to us with the actual chief complaint, particularly of I have a precancerous lesion. They will come to us with a toothache or some other problem, and we just coincidentally we see it's an incidental finding sometimes. Being an oral pathologist, I do encounter patients who have been referred and they are already aware that there are some lesions in their mouth, so they want to know what it is. But in case of the general practitioners and other specialties, it is very important to not tell the patient that they have a precancerous lesions right in the chair, right in that same moment. So first you need to get the patient, whatever the chief complaint is, address that issue. Talk to the patient about that, okay, it's a root canal which is required and we'll do this, we'll do that. After that, when the patient is relieved from the chair, you have noted down that, yeah, there is a lesion which you suspect that it's on the buccal mucosa. What you can do is just make them sit in your consultation room or just, at the same level as you, not when you're standing on top of them in the chair and you have to tell, oh my God, this is a cancer. Oh my God, this is an ulcer. Then what will happen? The patient gets scared. You have to first calm them down, make them sit, and then let's talk about it, that this is something which is suspected. It is not proven. No one can tell from the naked eye that, okay, this is a cancer. Once it is on the report, once on the biopsy, yeah, certain lesions are frank, certain lesions are evident. And even as a specialist myself, I don't immediately tell the patient, yeah, okay, this is looking like a cancer. First, I have to sit with the patient, counsel them, educate them, and then motivate them that, okay, this is the type of lesion we are suspecting. Don't worry, these are the lines of treatment which we can offer. and we'll try our level best to do the right for this particular lesion.
Next question. An OSMF patient suffering from impacted tooth. How long do we wait to do the procedure?
The procedure for the OSMF or for the impacted tooth, like that way, if it's either of the case, like it depends on the mouth opening. So once once we administer local anesthesia or once we administer injections, like intralesional injections, which we give in like the hyaluronidase and the steroid combination, so the mouth opening is gradually increasing. We at least wait for 2 to 4 weeks. Then at least if you have 30 millimeters, so depending on that mouth opening, you can plan out the particular third molar extraction. And once anesthesia as well, when we administer local anesthesia, patient feels less pain while opening the mouth, so the mouth opening does increase by a few millimeters. I would advise first to wait for at least, depending on the severity. If the impacted tooth is very painful, obviously the first would be to go for the prophylaxis, antibiotic prophylaxis, and then plan out at least wait for a few days and see the mouth opening. Otherwise, there are certain instruments which are available, like a jaw stretcher. Like a jaw stretcher can help with that. It's a slight opening. And you can use very fine instruments like the Warwick James elevators, and that can actually reach in that area, which are having a little angle, slightly bent at an angle, so that you can luxate the tooth and it can come out in one piece.
So recently, actually, I had one patient. He was suffering from OSMF long back, and he had come. This time, he had come for a filling and scaling. So hardly he could open his mouth for like hardly 25 mm. Okay, so even it was very difficult to reach to his procedures. It was very difficult to do the filling, and then after every like 2-3 minutes, he was like, "I'm having pain. I cannot open my mouth for so long." It was very difficult. But then at the end, and now he's having that trauma inside his head. So even after I did the filling, he's coming back to me and he said ki that filling has come out. That filling was very much there itself, but that was a composite filling. But he came back to me and he was like, "No, doctor, that filling has come out. Now it is pinching my gums." I mean, he's thinking in that way. Just because I've told him that, sir, you are having OSMF, and that is the reason you cannot open your mouth, stretch your mouth. So you need to go on, medication for this. And after that, he's having, some other thing only. He's like, your filling is pinching me inside my mouth. It has come out and it is pinching my gums. So how to treat and how to approach to these kind of patients?
The patients, some of them are in denial. Okay, they will not accept that they are basically having that particular thing, or they are continuing with the habit, and they'll be like, okay, that is not affected. The dental treatment which I had recently, that is causing the lesion, or that is also the patients are having their own mindset related to such things, because they are denial. They know that the tobacco or the pan masala gutka, whatever they are having, is causing that particular lesion. So they need to be actually counseled well. Sometimes even if it is beyond like counseling, for me, there is a tobacco treatment counselor that you can refer them to. So they will make them understand, okay, this is the kind of lesion or the problem that you have. This is the line of treatment and this much time it will take. So then they have some clarity, and always give them time. Then we can follow up with them so that they can also they can also go through literature, or they can also read on things. They are already aware tobacco causes cancer, everybody knows. This problem causes that, everybody knows, but they are always in denial. And it's not with me. That's why you need to sit with them and counsel them. That is not in the operatory. That is always at the consultation table. That they have to, you can show them pictures, or you can refer them to a consultant or a specialist. That okay, this is what they will need to emphasize on, and then we can plan out the treatment or related to whatever the fillings or the root canal is needed for them.
So let's move on to the next question. This is from Naman. He's asking why opening of mouth in OSMF is hard.
Why opening of mouth in OSMF is hard?
Yeah.
So why there is difficulty in mouth opening? Like if that would be it. So it's a progressive disease. It's a chronic disease. So what happens is there is fibrosis which is happening around the buccal mucosa. So there are these muscles of mastication. We have the all these muscles which are there, and even the buccinator which is there. So the muscle gets fibrosed. So the movement which is there, the masseter, all other like the pterygoid muscles, they get fibrosed. So the movement will not happen. Now we all are aware that the lower jaw, the mandible, is the movable part, movable component, and the upper maxilla is fixed to the skull bone. So the muscles which help in the movement, the muscles will help with the movement of the tongue. All those muscles get fibrosed, and that's why that causes the stiffness in the muscle, and it cannot be like that flexible what we like how we are talking right now when we are chewing food, etc. So that is a progressive disease. It becomes continuously becomes fibrosed, and that causes difficulty in the mouth opening. So that is where the whole process has to go in reverse. In certain literature, they even mentioned that the entire process or the first initial signs of OSMF, apart from the symptom, that is the burning sensation, is that the fibrosis or the atrophic uvula are seen. That is the case number which I showed. That is the last case. So that is in the posteriormost part of the oral cavity that the fibrosis begins. It progressively moves towards the part where in the corner of the mouth, when the muscles are there, everything, it becomes fibrous. That is why there is difficulty in mouth opening.
Can we proceed with the dental treatment in cancer patients? Because dental treatment is causing other problems. So what should we do?
Sorry, I didn't get that last question.
Basically, he's asking whether we should proceed with the dental treatment in cancer patients or not. Like if not, cancer is not causing any problem as of now, but the other issues are causing problems. So should we proceed with the dental procedure at that moment?
So the question, if it's related to cancer, so cancer is something which will be like a growth. It will be like an endoexophytic lesion, whether it's an ulcerated lesion. Anytime you encounter such kind of a thing where the patient is giving a history, for example, that ulcer is present for more than 15 days, that ulcer is present for more than 2 months, it is sometimes bleeding, but there is no pain. The priority shifts to that particular lesion. That has to be treated first, because that the problem is it widespread. If a dental treatment like a filling or a cleaning is required, I would always recommend that you can consult with the specialist first, like an oncosurgeon or a maxillofacial surgeon who are dealing with oral cancer patients, and then first go for a biopsy. Whether it's an incisional biopsy, then you can get it diagnosed. Okay, this has already transformed. It has become oral squamous cell carcinoma, and it requires treatment. So that priority changes if it's a cancerous lesion. But if it's a precancerous lesion, where the patient will ensure that they are following up with you, they will stop their etiological factors, they will stop the tobacco habit, and they are continuing the treatment. So that lesion can regress, it can go down, but you have to keep a strict follow-up. So you can continue the dental treatment in the precancerous lesion. Again, if it depends on the stage. If it's an early lesion, patient has to be made aware, patient has to be educated and motivated. Okay, this is what it is. But if it becomes like a proper cancerous lesion, then that should be the priority for the treatment.
Our next question is, can we do RCT or extraction in case of squamous cell carcinoma?
Again, I think my answer would be the same, that if there's a squamous cell carcinoma, and if that lesion is present in the same area, that is the line, like that has to be given the priority. If the patient is complaining of pain, first you should always go for a biopsy, because that is a question of life and death, that it can metastasize, it can cause a problem. So that should be the priority. Okay, if there is a frank endoexophytic lesion. Now in our session today, I couldn't share much on cancer because we had to focus on the precancerous. The entire aim was to understand it at that early level so that we can diagnose it and intervene. But if the question is related to that, the priority is obviously related to the cancerous lesion. Once that biopsy is done, that line of treatment should be in focus. Root canal, other things, if it's on the other side or the site is different, can be managed, but the patient has to be made aware. It shouldn't be that you're doing a root canal next to the cancerous lesion, that you are also overlooking it. It should never be like that. So always the oncosurgeon or a maxillofacial surgeon should be consulted. Ultimately, the biopsy would come to us, the oral pathologist, they will diagnose, and then we can plan the treatment out, whether it's a wide excision or whether it's a resection.
Okay. Before ending, we have one last question from Siva. She's asking, what are the other causes of OSMF other than areca nut chewing?
At one point in time, there used to be some literature saying that too much of spicy food can also cause the same chronic irritation with the areca nut. But now with the recent literature, it is proven that areca nut and the alkaloids which it forms, that is the irritant to the fibroblast, that what we have drawn in our cells and veins, that the fibroblast gets, that irritation is there, and then it undergoes fibrosis. So that is the areca nut, arecolin, alkaloids which form that are the byproducts. So earlier there was that, okay, chilies that was used to be there, the spicy food used to have capsaicin, that is the component of those chilies. Capsaicin can cause that irritation. So these are all added factors. So it is not that if a person is having only supari, that is the only cause, but etiology is there related to areca. Apart from that, the tobacco products, the other gutka products, the betel quid, which is again the component of areca nut, is there. Flake lime which is used, that is the tuna, what commonly people refer in Hindi. So those things are added factors.
Thank you so much, sir, for solving all the queries. And with this, we'll end today's session. Thank you so much for being with us. Thank you to all the participants for being with us. And with this, we're ending today's session. Thank you and have a great day ahead.